Okay, starting now, and here is your question. Right, so if you have read and understood, considering it critical care scenario, kindly tell me how would you manage this patient?
First, given that the patient is highly unstable,
Yes.
hemodynamically unstable, I would first do the CCRSP pathway, and we would first ensure that her airway is patent. And then after the airway, we'll assess her breathing and assess her look, listen, and feel, and for her breathing. And if that is all right, then we will move on to circulation. And ideally, she'll need two IV, the large bore cannulas in her hand. And she will first need to have bloods taken for FPC using ACRP and 2 grouping screens. And we'll also infuse 1 liter of normal saline in about 15 minutes as a bolus, just to see if her blood pressure is improving. After the circulatory management, then we would move on to assess her GCS, and if her GCS is fine, then we'll search for any other causes of why she has this hemodynamic compromise.
All right. Okay. Considering the condition, after reading the patient case and then taking history and establishing the after examination, what are the differential diagnoses that you might consider?
I'm looking at the fact that she's got a severe central abdominal pain radiating to her back. I would think of acute pancreatitis, and then I would think about acute cholecystitis, ascending cholangitis, or like a perforated viscus, perforated bowel.
Okay. Why would you consider acute pancreatitis as one of your differentials? What might be the causes? Yes.
Since acute pancreatitis, she's got pain radiating to her back. It's indicating of acute pancreatitis, and it also says that she's got pain after eating, which indicates that it might be pancreatitis. The causes of pancreatitis is gallstones, ethanol, trauma, and then steroids, mumps, or autoimmune diseases.
Okay.
And,
can you please, considering acute pancreatitis, can you please tell me the pathogenesis which lies behind it?
Pathogenesis can be first, must be duct obstruction. So duct obstruction can cause bile to flow into the pancreatic ducts and cause acinar injury. And then there can be direct acinar damage due to bacteria or trauma. And then there can be protease release that causes like white destruction of the pancreas and causes more enzyme release.
Yes,
and then
yes, please. Considering it acute pancreatitis, can you mention few criteria which can help you establish your diagnosis?
Yes, ma'am. There's Glasgow Criteria.
Very good. Tell me about it, please.
Glasgow Criteria is usually done on admission, where you look at 8 criteria, whereas PAO2 is if it's less than 8, age greater than 55, neutrophils greater than 15,000. 8 kPa. Age greater than 55, neutrophils greater than 15,000, calcium less than 2 millimoles, renal urea being greater than 16, enzymes looking at LDH greater than 600, and albumin less than 3.2 gram per deciliter, and
why do you
glucose.
Think a patient with acute pancreatitis has hypocalcemia?
Because the fat that is released, that is the fat saponification that's caused by the enzymes of the
Very good.
pancreas can cause, it chelates with the calcium, and so it
Yes.
causes hypercalcemia.
Very good. Okay. Okay. Right. Tell me how this criteria differs after admission.
So the Glasgow criteria is only done on 24 hours, whereas
Yes.
on admission, whereas the Ranson's criteria is done on admission and 48 hours post
Yes.
admission. So depending on the score, it indicates the mortality rate.
All right. Can you please tell me why the patient might be tachypnic?
First, it can be because of acute respiratory distress syndrome. It can be caused by acute pancreatitis. It can be because of pleural effusion.
Yes.
Or it can be because of
there is abdominal pain
well.
and then
Yeah, it can
what's
be,
happening?
Sympathetic overdrive.
Very good. Okay.
Yeah.
And there could be also VQ mismatch.
Yes,
all right.
Okay.
That, considering this to be acute pancreatitis case, how would you manage nutrition of this patient?
So nutrition is very important in terms of hydration and in terms of fluid.
Yes.
In terms of food. So for hydration, there's a chance that she will require more than like 6 liters of fluid. So adequate fluid management has to be done. And
yes.
Secondly, in cases of severe pancreatitis, we might need to give TPN, which is like total parenteral nutrition.
Yes.
And we'll also have to feed with nasojejunal feeds if it's not that severe.
All right. Okay. How do you plan to manage the pain of this patient?
So we do not give morphine or opioids because of the constriction of the opening of the duct. So we can give, however, we can give epidural, or we can give patient-controlled analgesia.
Have you heard of the term WHO's ladder, pain ladder?
Yes.
Can you tell me what that is?
So WHO pain ladder starts from normal, from paracetamol, and then moves up to non-steroidal anti-inflammatory drugs. And then it goes to codeine or any of these opioid-related families, and then analgesia, and then we can, in terms of morphine.
What is patient control analgesia? Can you please tell me?
So patient control analgesia is a device that gives you that gives you a limited amount of drug that's delivered within a certain period of time, and it has a breakout time in which the patient cannot get himself or herself administered with the drug. So this prevents overdosing, and this also prevents overdosing essentially.
Okay, and patient can have it according to
patient can. Okay. Yeah, it's comfortable.
If you do not manage the acute pancreatitis on time, so what are the complications that you can look forward to or you can expect?
So complications is we can expect a pseudocyst. If that at like about 4 weeks from the time of the pancreatitis.
Yes.
It can result in abscess formation. It can result in fat necrosis. It can result in renal failure and acute respiratory distress syndrome, and sepsis, and hypocalcemia, hyperglycemia, hyperalbuminemia, and also shock.
What is pseudocyst? Can you define pseudocyst, please?
Pseudocyst is a collection of amylase in a fibrous granulomatous tissue surrounding. This is located in the lesser sac.
Yes.
This is around the pancreas. Yeah.
This patient has serum amylase of 3,400. Oh.
Yeah.
Well, has gone. Okay. So yes, what is the normal range of amylase? How should it be? Like, is amylase important in scoring system, or how would you consider raised amylase levels?
I think amylase is not used in the scoring system.
Okay.
Because the amylase will return back to normal within 48 hours. So it's not very useful in terms of figuring out if there's acute pancreatitis or not.
Okay, Bell has gone, but then I want to know what are the two situations? Can you name two situations in which Even when there is acute pancreatitis, still
Yes.
you will find serum amylase level to be normal.
After 48 hours after pancreatitis, acute
This is one.
pancreatitis,
Yes.
that's one. And then even if we have pseudocysts,
No, in the too early situation, like when there it's too early to determine, levels can be
okay.
normal, okay?
Okay, ma'am.
And then the second one you already know.
Okay.
Right. Tired?
Sort of.
Yes, I covered everything, almost everything. So yes,
Yes, ma'am.
thank you so much.
No worries, ma'am. Thank you.
Yes. Any question? No. None. Right. If you have read and understood, considering it a surgical augmentation, kindly identify the marked structures. Can you identify 22, please?
Bear with me. Thyroid gland,
Okay, good. 17,
internal jugular vein,
okay, and 23.
20.
Oh, sorry, 8. Where is my cursor? 8. 8.
A. Is it the I'm sorry, ma'am.
Okay. All right. Can you tell me how the triangles are bounded in the neck?
So broadly, the neck is divided into anterior and posterior triangles.
Yes.
And then the anterior triangle is further subdivided into half submental, submandibular, carotid, and muscular triangle. And the posterior triangle is further subdivided into two triangles. It's the supraclavicular and the one I forgot the name.
Okay.
Yeah.
All right. Okay. Tell me about the posterior contents of the anterior triangle.
So in the anterior triangle, so in each of the subtriangle, like in the submandibular triangle, there is a submandibular gland, the submandibular gland, the submandibular lymph nodes, and then it got nerves, lingual and hypoglossal nerve, which are the main structures. In the muscular triangle, we have basically the thyroid cartilage, the thyroid gland, the recurrent laryngeal nerves.
Okay.
And in the carotid triangle, there's a carotid sheath which contains common carotid, internal jugular, and the vagus nerve with the sympathetic chain. And in the
Can you tell me the boundaries of the posterior triangle, please?
Yeah, so it is bounded interiorly by the posterior border of sternocleidomastoid, and posteriorly by the anterior border of trapezius, and inferiorly by the middle one third of the clavicle.
Okay, good. Can you identify this C here on the right hand side picture? C.
It's the sternohyoid muscle.
Okay. What is B?
It is the superior belly of omohyoid.
Okay. Can you please tell me the innervation of omohyoid, please? Okay. Right. Can you identify structure E, please?
E is the sternocleidomastoid, the sternal end.
Okay, good. And what about the D?
D is the clavicular part of the sternocleidomastoid.
What is A pointing at, please?
A is pointing at it's the supraclavicular nerves.
Okay, good. All right. If you can please tell me on the left-hand side picture, what is A?
A. Is there A in it? Is F and C? Oh, sorry. A is oh, sorry. Yes. Okay. So A is the superior lobe of the thyroid gland.
No,
On the right.
it's a vessel.
Oh,
See,
sorry.
it's
Is it
something
superior thyroid artery?
All right. What is E, please?
Is the isthmus of the thyroid.
Okay. What is G? What are the parts of thyroid gland?
So it's the superior and there's the right and left lobes, which are
Yes.
further divided into superior and inferior poles with the
Yes.
is joining the two halves. And sometimes there is a pyramidal lobe, which is an accessory lobe.
Okay. What are the blood supply of thyroid?
So it is supplied by the superior pole is supplied by the superior thyroid artery, which is a branch of the external carotid, and the inferior pole is supplied by the inferior thyroid artery, which is a branch of the thyrocervical trunk.
Okay. All right. What type of gland is submandibular gland?
It's a mucous gland.
Mixed.
Oh, sorry.
Serous and mucous. Okay. All right. Can you please tell me? All right. Can you please tell me the surface anatomy of the parotid duct?
The parotid duct extends from the inferior margin of from a line joining the inferior margin of the tragus to the middle of the philtrum, and
Okay.
The line at the middle 1/3 of that line is basically the parotid duct, and it opens inside the mouth upper jaw at the level of the second molar tooth.
What are the strap muscles? Can you name few?
So there are superficial and deep strap muscles.
Good.
In the superficial, there is the sternohyoid and the omohyoid superior belly, and in the deep ones, there is the thyrohyoid and sternothyroid.
Okay. What are their actions? Why are they called strap muscles?
So they basically depress the hyoid bone during swallowing and speaking. So they are basically involved in this movement.
Can you please tell me the nerve supply of the strap muscles?
All the muscles are supplied by the ansa cervicalis, except for thyroid, which is supplied by C1.
Okay. Yes, good. Okay. Right. Can you please tell me what is the nerve supply of the thyroid gland?
Thyroid gland is supplied by the recurrent laryngeal nerve and.
Okay. Yes. Can you tell me why thyroid moves during deglutition?
So thyroid is basically enclosed in one of the layers of the deep fascia, which is attached to the hyoid bone. It is the pretracheal fascia. So
Yes.
the pretracheal fascia is attached to the hyoid bone and the thyroid bone. Hyoid bone, the thyroid cartilage, and it extends down. And when it during deglutation, what happens is that when we are making this movement, this pretracheal fascia is lifted upwards, which is attached to the thyroid gland as well. So when the hyoid bone moves upwards, this thyroid cartilage moves up, so the thyroid gland also moves upwards.
Okay, good. All right. Can you please tell me the attachment of cricothyroid membrane? It extends from where to where?
It's between the cricoid cartilage and the thyroid cartilage.
Okay, so where would you do cricothyroidectomy if you have to do it?
Cricothyroidectomy.
Yes.
Then
You look up and you'll tell me. Okay, since we are doing thyroid, so can you please tell me what are the most commonly injured nerves during thyroidectomy?
So it's the external laryngeal and the recurrent laryngeal nerve.
Okay, and how
And
do you know? Yes,
vagus.
vagus. How would you know which nerve is injured?
Because of the presentation.
Yes, how? Give example, please.
If the external laryngeal nerve is damaged, then there will be the high-pitched voice will be compromised.
Okay.
And if the recurrent laryngeal nerve is damaged, then there will be paralysis of that side of the vocal cords, which
Yes.
will hamper in the phonation and.
Okay, can you please tell me the vertebral level of the thyroid cartilage?
It's C4.
Yeah, between C4 C5. Okay. Right. What is the most common thyroid cancer which spreads through lymphatics?
It's the papillary.
Very good. Okay. What might be the late complications of thyroidectomy? Can you name few?
So they can be late complications, yeah. So they can be
hypothyroidism and hypocalcemia.
Yeah. Okay. Yeah.
All right. All right. Okay. One last question and then I'll let you go, please. Can you tell me the embryology of the thyroid gland?
It develops from the foramen cecum, and it descends down. I can't explain.
Okay. Maybe they can ask you to draw and tell them, or so you have to learn this. Okay.
Yeah.
Right. Just. Yeah. So you told me the blood supply. Okay, thyroid is covered. Parotid, I just touched upon. I didn't ask you much.
We didn't know that we had to do all these glands as well. I thought I did a few, but that was just.
Yeah, no, this head neck is very important. Something definitely comes from it. So if they won't ask you skull, then they'll ask you triangles. What was something we did last time? Yes, yes, sinuses as well, dual sinuses. Yeah, 2-3 things are very like their favorite, and thyroid is very favorite. Like thyroid examination is there, history taking of thyroid is there. Thyroid comes in one way or the other, so it's better to do thyroid and parotids and submandibulars. These three, like, do them very well.
All right.
This is like my advice. If they'll not be asked in anatomy, they will ask in examination or history taking or somewhere, right? And then they can ask any question. They can go like, it depends, I don't know how the flow is going, they can ask you or they can take you anywhere. So if they just realize that your basics are weak, they can just make you stick on that. Like, so it's why to take risk, you know, when we have time, we can just prepare ourselves very well. So, right. Thank you so much.
Can you please